All right, I think let's go ahead and get started here because
Yeah.
we want to maximize the time that we have here with the excellent guest speaker for us today. So we have Dr. Timothy Morgenthaler from the Mayo Clinic with us today. We're going to be talking about sleep apnea. I think focusing specifically on obstructive sleep apnea primarily. And so Dr. Morgenthaler is a professor of medicine at the Mayo Clinic in the Division of Pulmonary and Critical Care Medicine, and also does sleep medicine and serves a number of other administrative roles like vice chair quality for the enterprise and vice chair of practice innovation for the department. It looks like he did his education at MIT for undergraduate, Dartmouth for medical school. We were kind of diving into his past a little bit before everyone logged in about his general surgery internship at the Naval Hospital, but then ultimately went to the Mayo Clinic where he did his internal medicine residency and stayed on there for fellowship in pulmonary and critical care medicine. And so just a very impressive kind of CV here and a great speaker to have with us. So we're really excited you're here, Dr. Moreland. Welcome to KU.
Well,
John,
thank you for inviting me. Yeah,
we'll let you kind of kick it off.
Okay. So we have a little bit less time today, so we're going to be stopping at about 12:50 today. And this is a huge topic to get through. We will do our very, very best. But we are going to talk about sleep apnea and primary care. And so I listened to, is it Morgenthaler or Morgenthaler?
Morgenthaler is I
Morgenthaler. Okay, perfect. I heard Dr. Morgenthaler talk on Mayo Clinic Talks. He was featured in one of their podcasts, and it did such a great job at really describing the importance of obstructive sleep apnea and sleep apnea in general in terms of morbidity and mortality in the United States and importance of treatment. And so it was a pretty awakening podcast for me to listen to. And so I really wanted to bring him in. I can't thank you enough. So our objectives for today are to understand the morbidity associated with untreated sleep apnea, discuss which patients may need screening for OSA, and review treatment modalities for mild and moderate to severe obstructive sleep apnea. And we'll touch on a lot of things in between there, but those are kind of the big things that we want to take from today. So if we set the stage, Dr. Morgenthaler, I'll just kind of let you kind of give your spiel about what morbidity and mortality looks like with untreated sleep apnea.
sure. Well, I think so. Obstructive sleep apnea. What usually comes to people's minds is snoring and sleepiness, and those certainly are some cardinal symptoms. But the way I tend to view obstructive sleep apnea, particularly now after working in this area for 20 some odd years, is it's certainly not just about sleep. Sleep is extremely important. Don't get me wrong, but sleep apnea in particular, I think, is a cardiometabolic disease amplifier. I mean, it really is not very healthy for you. I would also say that I think of obstructive sleep apnea now more and more not as just an airway disease, and I say that because I think unfortunately I think as a field we've been a bit myopic. Over the last 20 years, we've just concentrated a whole lot on what I'll call airway maintenance therapy. I have a patient, they stop breathing a certain number of times per hour. I'm going to keep their airway open, and that's going to fix everything. And I think what we've learned, at least what I think I'm seeing, is that it fixes a lot, but not everything. These patients they have complicated symptomatology. I think it's a multi-system disease, and I think you're going to see the treatment of sleep apnea branch out quite a bit in the coming years, just like it did with, let's say, heart failure or diabetes, which, way back, maybe when I was in medical school, we treated diabetes with diet and insulin. And now, you all as primary care physicians, internal medicine people, you have somebody with type 2 diabetes, and I would bet you've got 5 or 6 medicines, just out of the gate that you're thinking of to treat the various aspects. I think sleep apnea also is a multi-system disease. It obviously has strong associations with hypertension, especially resistant hypertension, atrial fib, stroke, coronary artery disease, type 2 diabetes, depression, and motor vehicle collisions. So all of those things. And I guess I would start off with that. I don't know if that um, answers your question, but those are the things off the top of my head.
Yeah, I think that it certainly does. I'm curious if anyone has ever kind of postulated why cardiovascular risk and stroke risk go up so much? Is it just the untreated hypertension? Is there something underlying from just having obstructive sleep apnea that raises those?
Yeah, so pathophysiologically, as this has been studied, there is a pretty good sort of causal chain, if you will. Both sleep fragmentation and in particular, and not or, but and in particular, episodic hypoxemia really drives sympathetic activation. It really drives endothelial dysfunction, inflammation, and insulin resistance. And so if you kind of take those factors of sympathetic activation, endothelial dysfunction, systemic inflammation, and insulin resistance, you can really start, branching from those to a lot of these sort of end organ target morbidities and mortalities, I think.
Okay. Brandon, do you have any questions?
Well, we might get into it, I think, but I think I remember somewhere along the line of my training or reading or something, I have something in the back of my head that says that I remember if treating sleep apnea does not improve mortality. Is that true? I mean, it seems like it should, with all those things that you're kind of describing.
Yeah. So I mean,
studies that kind of back that up, or is it?
Yeah. So this is an interesting point, and I think our field is very frustrated right now. Um, let's just take first of all mild obstructive sleep apnea. Um, for mild obstructive sleep apnea, which right now we define the disorder on, by counting respiratory events per hour. So we'll say 5 to 15 apneas and hypopneas per hour. For that, at least CPAP has been the most studied. It doesn't clearly prevent heart attacks or strokes at a population level. It does decrease blood pressure reliably, although not as much as maybe some of our blood pressure medications, but it does pretty reliably reduce blood pressure. The major randomized trials, of which there are quite a number now, all of them relatively small, mostly have studied, unfortunately, non-sleepy patients with established cardiovascular disease. And in those patient populations, it doesn't really seem to show an overall reduction in major cardiovascular events, even with CPAP. But I will also point out that not only is that not much like most of our patients, because most of our patients do have some sleepiness, but the adherence in those trials, those prospective trials, has been very poor, averaging about 3 hours per night. Now, if whenever this happens, of course, I think probably all of you, and I know I've many times seen patients who really seem to benefit from CPAP, then you kind of go, well, why is that? So if you actually go back in those trials and you look at not just intention to treat, but you say, well, what about the patients that actually used CPAP, that actually used it, not to, well, actually, those who use it more than 4 hours per night, there is evidence of fewer cardiovascular events, and newer analyses really suggest benefit in what we would call the highest risk patients. And I think we're becoming more aware of this because we're going back and look at these data. So the AHI is a stratification that we kind of made up 25 years ago, so mild, moderate, severe. But what we're finding out is that hypoxic burden is probably a more sensitive indicator of risk. So higher hypoxic burden or stronger heart rate surges after events seems to be a marker, a physiologic marker for higher risk. And in those patients, treatment actually does seem to result in improvement or reduction in events. So in clinical practice, particularly on the milder end of sleep apnea, we tend to definitely let's treat for symptoms because there's a lot of evidence that we can improve symptoms and quality of life. For cardiovascular risk, you probably have to be much more individualized and talk with patients about what their goals are, how comfortable they are with this sort of gray area of data that we have. Because again, the prospective trials, only after sort of analyzing them for usage and maybe high risk factors, definitely a benefit. But there's a lot of data out there, observational studies that do show a dose response relationship with treatment and improvement in cardiovascular outcomes, particularly when you get into more moderate and severe sleep apnea. So it's a nuanced answer to your question. I hope I captured it okay.
No, that's great. Yeah, because I was thinking, I have thought about it probably, too simplistically, right? Around that, where, I'm really kind of focusing more on symptom reduction and things like that. And we know a lot of people don't like CPAP machines and things like that. So sometimes it's hard to know how hard we need to push on these interventions when patients don't necessarily like them. I think when there's a mortality difference, I think we push a little harder, right? Or a lot harder in a lot of cases, right? Our medicines that have that kind of mortality benefit, we always push much harder than we do medicines that are purely symptom driven. So I think that's a really helpful answer for me to kind of understand this as I can think of many of my own patients right now that, the counseling that I will be able to provide will be a little bit different. So.
Yeah, the intention to treat analyses and studies is always difficult because, like, we just ran into that in primary care about 2 years ago or 3 years ago with colonoscopies. And there was an intention to treat study that came out and said they actually don't reduce morbidity and mortality, but it was only if you offered colonoscopy and not actually getting the colonoscopy itself. And so it's just like patients came to us and they were just like, it actually doesn't do anything. And it's so difficult because it's not well labeled and you really have to read into it. So that's why we bring people like you on, because we don't get to read that far into these studies.
Well, I'll just go a little further, and maybe this is
Please.
going, farther than you want to, but this has really caused the field. There's a great deal of dissatisfaction with using counting events as our marker for severity of disease, because now on more reflection, we're learning that, hey, there's other signals here that are actually much stronger for who's going to benefit from therapy. Um, but the problem, of course, is we'll have to have an overwhelming amount of data and research, funded research, before we can go back to the payers and say, hey, let's not use the AHI anymore. Let's use hypoxic burden or one of these other things. So we kind of have a problem where I think there really does need to be a sea change in the field in terms of how we define disease. But we all can sit in an echo chamber of academic towers and define what works, but we still can't treat our patients without the old things. So we have a bunch of work to do there.
Yeah. Okay, so let's jump in. So this is a 52-year-old patient that came to see me. He's coming in to discuss his ongoing fatigue, and I guess the word really that I'm getting after is sleepiness during the day. We have a standard kind of laboratory workup. We screened him for depression, and you start to kind of think of other causes because everything's coming back negative. And you ask him if he snores at night. He says he doesn't know because he doesn't have a partner. But when he was younger, like in college, you remember his roommates would complain about it all the time, and he's put on some weight since then, probably. And so I guess I'm curious at making this more general, not so much about this patient, but in general, like what questionnaires are we using to help us decide whether or not screening someone for sleep apnea and going to a sleep study would be a reasonable kind of next step for a patient?
Yeah. And so, you've got a few options here. The Epworth Sleepiness Scale, which I think you're all probably familiar with, 8 questions, uh, possible maximum score of 3. It's really not a sleep apnea screening tool. It's a sleepiness tool. And it's not even a great sleepiness tool. It's just that it's very well embedded and somewhat reproducible and so forth. So it is not a good screening tool for obstructive sleep apnea. The stop bang has actually been probably shown to be the best sensitivity, especially in primary care. The Berlin is also good, but it's a lot more questions, and it's hard to get patients to sit there and fill it out. We're finding that many elements of the stop bang can be filled even from retrospective or recent retrospective data inside the health record. It doesn't take very long to do. It's not perfect, but if you're seeing a stop bang score of greater than or equal to 3, then you really definitely should be thinking about sleep apnea. And of course, there's even some reason to think about greater than or equal to 2. So, I think of those options you've offered, clearly I would put stop bang in front as being a pragmatic and reasonable screening tool. But we do have to listen to our patients. You mentioned an important thing that I just actually learned about last year, sleepiness and fatigue. Boy, we spend a lot of time in the sleep center here talking to patients about the difference between sleepiness and fatigue, and we've come up with all kinds of thoughts about it. One of my friends and colleagues, Ron Shervin, who's a neurology sleep medicine specialist at University of Michigan, published a very interesting study. There's a couple things interesting about it. First of all, how often does a professor of medicine be the single author on an article published in a major journal, is published in Chest? I think that's fascinating because what that means is nobody else wanted to help him with it. But it was a really interesting study. And what he did was he questioned patients about, well, are you sleepy or are you fatigued or are you both or tired? He had a whole list of questions. And actually, a lot of the patients that were being diagnosed with obstructive sleep apnea selected fatigue or tiredness rather than sleepiness. And that's very informative because, I think there's a real tendency to try to weed that out and say, well, if you're fatigued, treating your sleep apnea, even if you have it, isn't going to help. But actually, he did find that people's symptom, whatever that was that they had, did tend to improve. And so that is a good question there. And I think you're right in this patient when you're thinking about, he's exhausted or fatigued, to not discount that, hey, this could be actually a sleep deficiency or sleep disorder.
Right. Um, the stopping, do you guys you kind of mentioned, I feel like it makes sense, especially with AI and things combing through our notes and data and the records. Do you guys have anything that suggests to providers to say, hey, they're at least a score of 2 or 3, consider sleep apnea embedded into your EMR?
We don't have it automated. We have as part of our general questionnaire a couple kind of sleepish questions. One is about loud snoring, and the other is not feeling well rested when you waken. I'm not sure that they're the best evidence-driven questions on the general questionnaire that like everybody who comes here would fill out, but that often triggers our primary care doctors to inquire a bit deeper. And I'm not recommending this. I'm just telling you what they do. They either then go on to complete the stop bang, or not uncommonly, they may get an overnight oximetry, which is cheap and inexpensive, and they can have the results the next day. And they then use that to look at the pattern which they see to begin to sort of triage in their minds how important is this to track down.
Mm.
But that's what I would say is done in our primary care practices. Now, our primary care physicians in Rochester can order a home sleep apnea test. So if they see enough there, either by the stop bang or by other strong clinical suspicions, they may consider ordering directly a home sleep apnea test.
Because it's interesting, and you talked about this on the podcast, but it was something where you talked about overnight oximetry in general and how it's not actually a great study to rule out sleep apnea. It can help you, but in my workflow, I feel like if I'm strongly suspicious, regardless of those results, I'm probably still going to pursue a more formal test. I don't know if that's reasonable.
Well, I would say that it is. In fact, when I first came on staff here, maybe the second or third year I was here, I collaborated with Kurt Rodesil, who was in our general internal medicine practice. And because he and I would talk, at the gym or over lunch or something, I'd say, why are you guys ordering all these overnight oximetries? And he said, oh, because, it takes so long to see you guys. And I said, yeah, but once you get the results, then what do you do? And so we had a spirited discussion. And I said, well, look, why don't we just look into this? Why don't we look at, 150, I don't remember whether it's 100 or 150 patients of general internal medicine where you ordered an overnight oximetry. Let's see what the results were, what was told to you by the pulmonologist reading it, and let's see what you did. And, he would have sworn that what they're doing was screening, which by definition really should be done in an asymptomatic population, but we won't go into that. But they weren't really making a decision about whether to refer the patient or not refer the patient based on desaturations per hour, or they were really kind of looking at, well, how deep are those desaturations? That must be really bad if it's really deep. Turns out they might have been right about the hypoxic burden, but really what they were doing was triaging, because usually patients that are coming here to general internal medicine, they're coming with like 8 problems. Please sort these out. I've got cancer, I've got rheumatoid arthritis, I don't feel well, my toe hurts, my eyeballs itch, or whatever. And they're trying to sort out, kind of how to approach those different things. And so they've been using the oximetry. I would say that practice has very much changed with the much wider availability of home sleep apnea testing. And I and my colleagues have been trying to convince them, and I think with some success, which we're now suffering from, but to say, hey, like you, John, if you're looking at a patient and you think they have obstructive sleep apnea, especially if they have maybe a higher pretest probability of having at least moderately severe, let's just do a home sleep apnea test and get this done with, if it's appropriate.
Mhm. Yeah, that's my workflow, and like you talked
Skip a
about.
test, skip a useless test.
Exactly, but then it becomes pulmonology's availability. We talk about that a little bit because it's just like it seems like everyone that I test has some form anyway. So we'll kind of get to that, and And Dr. Crowley has a really nice question. We kind of get to it with the second stem is that if you're deciding to test someone for sleep apnea, are there situations in which you jump to a in lab sleep study versus an at-home sleep study? I think insurance requires that.
Absolutely. Absolutely. The answer to that is yes. Um, and I don't know, do you want to wait for your case or do you want me to just talk about
No,
it right now?
please go ahead.
Well, so let's first pretend for a moment that we're being clinicians and scientists and not being insurance people. The conversation will change a little bit. Um, Home sleep apnea testing is, I think, very reasonable in uncomplicated patients, and I'll define what that means in a moment, who have a high pretest probability for having probably more moderate to severe sleep apnea. So, this is the, you know, high BMI person that's falling asleep and snoring in your waiting room, and you're just looking for a number to verify that you can give them some treatment. You kind of know they have it. That type of patient, high stop bang score, maybe that kind of person. Um, but if that patient has heart failure, you've got a problem because most home sleep apnea tests will not differentiate between obstructive and central sleep apnea, and they have they have about an equal chance of having one or the other. Okay, so that's not a good test. If they have neuromuscular disease and you're worrying about hypoventilation, home sleep apnea testing, yes, it'll still diagnose whatever sleep apnea they have in their hypoxemia, but now you're not going to really know how they respond to CPAP. Whereas you could figure that out in the lab and you could decide whether they need CPAP or a bilevel device or, how bad are things. So neuromuscular disease with any concerns about hypoventilation, or if you're really seeing a patient who has obesity, they have probably sleep apnea, and you're seeing a bicarbonate level that's 28 or 29, they probably have some hypoventilation. You may want to rethink that about a home sleep apnea test. If you have other reasons, let's say they have significant pulmonary disease, where a home sleep apnea test may not be very accurate, or let's say again they have other reasons to suspect they have central sleep apnea. They're on moderate to high chronic opioid dose or something like that. Or so for all of those, and atrial fibrillation in some cases, it depends on which test you're thinking of. Atrial fibrillation can confuse the watch pat and the night owl and so forth, the pat-based devices. It's not good to do it on them. So those are all with, gee, I think this person has a sleep apnea-like disorder. It would be much better to put them in the lab. One other end of that extreme is, golly, I think they have sleep. I don't have another explanation for why they're sleepy, and I still think they might have mild sleep apnea. You should really prefer to do an in-lab study. So you have a high pretest probability, but a low severity. That patient, John, that had the normal oximetry, but you swear up and down they have sleep apnea, that person should go in the lab because we can actually see what's going on with their sleep and their breathing and so forth. It's important to know that home sleep apnea tests, all of them tend to underestimate the AHI, especially at the milder threshold. So that's why you want to really load the patients that you think have higher AHI. Your impression is that they have a higher AHI. So it's Bayes' theorem, okay? It's Bayes' theorem in action. Then the other kind of category is what if their complaint is a parasomnia? They're doing unusual things at night. They're acting out dreams. They're sleepwalking. They're sleep talking. They're having, a home sleep apnea test is a home sleep apnea test. It's not a sleep test. And you won't see those things. Whereas an in-lab polysomnogram will give you much more information about that patient.
So I guess if you're not looking at the parasomnias, the other things, the chronic opioids, the heart failure, stuff like that, things that are where you might get more central sleep apnea. It's not necessarily that the home sleep study will be a bad study, but it's just not a complete study. You'll still get information.
Well, you'll have to end up repeating it, or else
Right.
you'll send your patient through a misadventure. Because let's just say you were not being very mindful of this, and you've got a patient who's got an EF of 25, and they're giving you the history. I don't feel well rested. I don't sleep well. My wife says I have pauses during breathing, and you do a watch pat, okay? And it comes back and it says, yep, the AHI is high. And so what are you going to do?
Right.
You're going to put them on a CPAP.
Yeah.
And, about 85% of the time, that's going to be intolerable, not effective, might make them feel worse. So that's not going to be very helpful. Whereas if that patient had gone in the lab, within the first couple hours, you'd know that they have central sleep apnea. And then we could go on to try CPAP for a brief period of time, see if it's helpful. And if not, go on to an ASV or get them on track for a phrenic nerve stimulator or something like that. So we can really be much more efficient for the patient.
And I do feel like if we're talking about patients with heart failure, stratifying them to an in-home versus an in-lab, I feel like it's important because all my patients have grade 1 diastolic dysfunction. What severity of heart failure are we looking at to say, okay, this really warrants in-lab?
Yeah. Well, I think we know that you can see central sleep apnea with both diastolic and systolic. So both HFpEF and HFrEF, you can see it. I don't have the numbers for this, so that's a good question. But I think it would be, I'm pretty sure I'm right that if we looked at, HFrEF, systolic dysfunction, that I would really say, if you can, just go to the lab first because you're just going to be much more likely. Now, I'm not talking about, 48% unless you can see they're visually compensated. But, if we're talking about somebody who really has heart failure with a reduced ejection fraction, they really should probably go to the lab first if it can be arranged because you're going to be much more comfortable with the diagnosis and it will help with treatment design. I think with the diastolic dysfunction, as you say, I mean, the cardiologist can put a number, very mild diastolic dysfunction. I think there you should have clinical heart failure, not just a stiff ventricle. Do you have clinical signs of heart failure, or have they had that? They still probably should go to the lab in those circumstances.
Thank you. That's extremely helpful. Okay. Continuing the case, and let's see. So he completes a sleep study, reports that his sleep apnea is mild, and that he may benefit from CPAP versus oral appliance versus weight loss versus positional therapies. So how do you counsel patients? I guess we kind of already talked about this, and so I do kind of want to move on just for the sake of time. So if someone has weight loss and they start using oral appliance or they're on CPAP, is there any evidence that repeating a sleep study is beneficial and seeing if they still need to do those things? Is there any time when you might repeat one?
Well, so absolutely. So let's just talk about oral appliances for a moment. Of course, there's a lot of information that you left out of the case, but my discussion with this patient would probably be, okay, it appears you have mild obstructive sleep apnea. You have symptoms. He has fatigue. So I would say treating your sleep apnea, I think we have good reason to believe would actually help improve your quality of life, improve your energy level. They can't prove it because there's a lot of causes for fatigue, but you've looked for those already, and this seems to be abnormal. We should consider treating it. But then we should talk about how to treat it. And the way I have that discussion with patients is I say, well, of all the therapies, the most predictably effective in relieving sleep apnea is CPAP. And we talk about how that works. And then I tell them, there's good and bad about CPAP. The good is it's relatively inexpensive, almost no risks. I've never seen a death certificate dead from CPAP. So it has those going for it. Unfortunately, it's not always comfortable for everybody. And it takes some getting used to. But, it's safe, cheap, and efficacious. So those are the good things. But we should talk. What about oral appliance therapy? Oral appliances actually can be very effective for patients with mild obstructive sleep apnea. It's about maybe 60%. And there's some features in their clinical exam and so forth that can help, modify that percentage. But we're in the 50 to 70% range. And if they're in the 50 to 70% of the people, then that might be a great therapy for them. So I offer those up front as a possibility. We have to discuss it and talk about the pros and cons. There are some other options for mild obstructive sleep apnea. The Excite OSA is an intraoral tongue stimulating device that has some data for mild obstructive sleep apnea and snoring. It's FDA approved. Actually, Medicare is even approving that device now. And what about weight loss and lifestyle modification? So we have to talk about all those things. Now, when we use CPAP, we don't most often need another sleep study because the CPAP devices now have built into them the capacity to show me whether their breathing events per hour and so forth are going down. So that's nice. Oral appliances, at least right now, do not have that capacity. So if my patient selected an oral appliance, we talk about how that goes. And then I tell them that once we have it titrated to the target, which is set basically anatomically, if you're tolerating it and you think you're going to continue with it, let's do a home sleep apnea test and verify that we've got improvement. And that is the recommendation of the American Academy of Sleep Medicine as well. Let's say that we do that and we verify that it's working, and now he loses 15% of his body weight by a miracle or by drugs or by whatever surgical approaches. Yeah, we should take time to see if the patient still requires any form of additional appliance therapy for sleep apnea, because that could result in significant improvement in their AHI. We won't know if we don't measure it.
Okay. Yeah, I struggle with the oral appliance question because they're so expensive and patients will ask, well, do you think I should get one? And I say, you could try it. But if me just saying like try it is hundreds of dollars out of pocket for patients in and
You know, the insurance coverage, at least up in our region, is the same for an oral appliance as it is for CPAP. So
really.
it's not particularly more or less expensive.
Hmm. Okay.
So
Mikali, I'm sorry to call you out, but you're just the one on right now. Do you find that oral appliances get covered here pretty easily?
I was actually just going to ask. I've never ordered an Excite oral appliance. My husband got a dental appliance from his dentist that was very expensive and not very effective when it's not worn at night. So,
yeah. So a
If
couple of thoughts about that. So when I refer patients for an oral appliance, I make sure that they go to a dental sleep medicine specialist, not just a dentist.
Mhm.
And so you can find out who that is by going on to the American Academy of Dental Sleep Medicine and putting in the zip code that's closest to the patient and putting in a mile radius that they're willing to travel. And you can tell right away whether there's board certified dental sleep medicine specialist in their area. And that would be the person to send them to. So that's number one. Number two, when you don't do that, sometimes what happens is, and I hope this didn't happen to your husband, but the dentist charges you dental fees rather than submitting it to medical insurance. It is actually a medical treatment. You're asking a dentist to supply a treatment for a medical disorder. And if they submitted it as a medical bill to your medical insurance, in most states it is covered, and even Medicare covers oral appliance as treatment for obstructive sleep apnea.
Okay.
and
No idea.
and if I may speak up really quick, my name is Sam. I'm one of the nurse practitioners in the clinic, and I used to work as a nurse in sleep medicine. I
Yeah.
actually do have a dentist that I could share information with the clinic with who works really well at getting insurance coverage for oral appliances. And one thing I always counsel patients about with them is that if you look at the cost of CPAP therapy over the lifetime for somebody with mild sleep apnea versus an oral appliance, it is actually cheaper in the long run.
Cool. Yeah, if you could share that, that would be wonderful. And I think Courtney Rudy just shared someone as well. So this is awesome, the strength of numbers. Um, okay.
thank you.
So, and then I guess a brief question is for the Excite OSA, are there similar limitations as like with Inspire therapy? If you have like a nerve stimulator, do you have, I mean, are there weight requirements that you have to be
Yeah.
cognizant of?
So the Excite OSA is quite the new kid on the block. There's really not a lot of data with it. My own experience with it, I probably have treated maybe 70 patients over the last 3 years with it. Patients often, but having said that, it's only been covered by insurance, supposedly. I don't have that, but for maybe the last 9 months. So it's not frequently chosen, although I discuss it with patients with mild sleep apnea and snoring. The data is better for snoring, but I think there's two published, peer-reviewed papers, probably amounting maybe 600 patients. It does show very modest improvement in sleep apnea. We're talking about a decrease in AHI of, maybe 5 to 7. So it's really for patients who are kind of down there, in their breathing. My impression is it's less likely to work on a terribly obese patient, which is just going to require a greater, muscle responsiveness. But I don't have data to support that impression. That's just the impression. And of the 70 or so that I've sent off with therapy, my practice is a little unusual because some of those might go to Taiwan and I'm not seeing them back. But for those that I have seen back, I'd say it's actually had some reasonable effectiveness, and has had pretty good adherence. So I put it in my list. I wouldn't say it's not the first tool that I pull out of the tool belt, but I mention it in patients who have very mild sleep apnea and are really not keen to even consider CPAP or an oral appliance. Oral appliances certainly have much more data behind them as being very reasonable alternatives to therapy.
Okay, thank you. All right, let's go on to the second case. So this is really just getting at kind of more severe sleep apnea and kind of what we do in this territory where we are almost forced to take care of it before they see a pulmonologist. And so just some tips, tricks. So the case is a 32-year-old patient presents to established care. Their BMI is 41. They have uncontrolled hypertension on 3 medications. During their visit, you adjust their antihypertensive regimen and get a secondary workup, which comes back negative for any obvious biochemical causes. You continue to manage his blood pressure, but wondering if there could be other contributing factors. We've kind of talked about other situations in which you might screen for obstructive sleep apnea. So I'll move on because I know we already have some questions in the chat about treatment, but you pursue an in-home sleep study, and this shows severe sleep apnea. Unfortunately, an appointment with a sleep physician is 6-month wait, and you feel that you should start the patient on some sort of positive pressure ventilation. So I guess we can talk about counseling, but if we could talk about instances where you might jump to BiPAP if there's situations in that, and kind of what your order looks like for CPAP in initial treatment.
Sure. For initial treatment of a patient who has, as far as I can tell, uncomplicated obstructive sleep apnea, and what I would say on the sleep study, is their mean saturation greater than 90. I don't have any reason to believe they're a terrible hypoventilator. They just have a high AHI. I won't start a BiPAP. I'll start an auto-titrating CPAP device. And I typically write for a minimum pressure of 5 and a maximum pressure of 15. The mean treatment pressure for most patients is about 9, but it's influenced by a variety of things. And I find that most patients will have a treatment pressure that arrives someplace certainly in that range. And, typically it's going to be between like 9 and 15. Some will be higher, but you're going to see them back in a month or month and a half, and you'll have information on their download to know how effective that is in controlling their sleep apnea. So I use that. I don't go to a BiPAP. A BiPAP, and I assume here you're talking about a BiPAP S, spontaneous
Yes.
mode BiPAP. I use very rarely for obstructive sleep apnea. We tend to use it when the patient is very pressure intolerant, or in some cases where they're an obesity hypoventilation patient that isn't improving with CPAP. You might consider using a BiPAP under those, a BiPAP S under those circumstances.
Okay. So, and this is something that we don't get much training in, obviously, but when you get someone back, say I started a CPAP machine, and Ben Quick actually asked this question, what are you looking at on their report to say, oh, I need to adjust X, Y, and Z, maybe we need a new mask? How do you approach that generally?
So you're saying now I'm seeing the patient back and I have a download report?
Yes. Yep.
This is a whole hour talk, but I'll try to tell
So
you.
I know I was
Like
thinking like this is its own thing. So
Well, so there most do you all see mostly ResMed machines, or do you have a lot of Philips machines? You don't know. Okay. Well, it's probably the most common right now since Philips kind of had big problems. Most
ResMed.
patients are on ResMed machines now. Up here, a lot of them, vast majority. So usually you're going to get the compliance and therapy report. And right there on the front page, my eye first goes to the bottom where there's a little graph that shows you their daily hourly usage. You need to be aware that that's their cumulative daily hourly usage, so you don't really know what their pattern of sleep is. But green is good. If they're more than 4 hours per night, it's going to be green. If it's less than 4 hours per night, it's going to be red. And so you right away can get a sense of, how consistent are they in their sleep pattern. And that's kind of helpful, I think, in counseling the patient about their sleep. Closer to the top of the page, it'll start giving you, what is their average nightly usage? What percentage of the nights are they using it for more than 4 hours per night? And how many days out of the last, however long you made the report for, did they actually use it? So, what you really want to see is they used it 99 to 100% of the nights, always over 4 hours, and their average, usage is 7 hours. That's what you'd love to see, 7 hours. And it's quite consistent when you look at it. Going further down the page, you're going to see a section there where it's going to tell you what the median, the 95th percentile, and the maximum pressure is. And that's going to tell you whether the parameters you set around your auto-adjusting machine make sense. If you set it from, let's say you set it 5 to 12. I don't know why you did that. You set it 5 to 12. And every night their 95th percentile and their maximum is 12. and they have residual apnea-hypopnea index, you set the maximum too low. You're going to have to go up on it to give the machine permission to go higher. Does that make sense?
Yeah.
Okay.
Mm-hmm.
So you can adjust that range if you wish. If they're doing fine on the 5 to 15 range, I actually don't usually adjust it a lot. There are some zealots out there that feel that auto-titrating machines aren't as good for blood pressure control and so forth and so on. I'm a little pragmatic about it. If it is working, let's leave it be. And so I just leave that be. The next kind of thing you can look at is leak. Both the Philips and the ResMed is going to tell you about leak. And leak is important because leak usually correlates usually with comfort of the mask. And so if you're seeing a lot of leak, then you need to start thinking about, well, why are they having a lot of leak? And there's the major causes for leak are patients not putting it on correctly, poorly sized mask or poorly, type of mask, and sometimes mouth leak. And this again would be a whole nother talk, but really most patients should be managed with a nasal CPAP rather than oronasal CPAP. There's some perverse incentives at the DMEs to supply them all with the big CPAP mask that you see on all the Inspire commercials. That actually is not what most patients do well with. Most patients do better with a nasal mask. And then after you address the mask issues, then again, there is an estimate of efficacy down there. They're counting respiratory events per hour. Most of the machines try to differentiate whether it's a central event or an obstructive event. It's the apnea counts are pretty accurate. The hypopnea counts are approximate. I'm usually looking for a patient who's symptomatically doing well and the residual AHI is less than 10. If we have that, I'm feeling like we're doing pretty well. We can quibble over that, but that's a nice target.
Okay. And that's kind of what we're going for, right? I mean, with like primary care, we're really just trying to triage someone until they can get to pulmonology and do a good job treating their symptoms.
If you're getting that and you have them working, you don't need a pulmonologist. You're done.
Okay.
You can manage these people. It's not that complicated if it's working for you.
Okay. Yeah, that's good to hear. I feel like it's so reflexive from my standpoint to just engage a pulmonologist immediately the second someone has moderate to severe sleep
So
apnea.
I'm going to make a shameless plug.
Please.
You all need to sign up for the Mayo Clinic Updates and Sleep Medicine course, which is in Vancouver in July. It's a wonderful course. You'll hear a broad spectrum of things. It's all case-based learning. It's time for networking, and you'll get a lot more comfortable with these things. So check it out. This year it's in Vancouver. Next year it's in Kauai.
Maybe I'll save it for next year. No, I'm just
You'll
joking.
probably come back. We have a lot of people who come back for both. It's really been received very well.
It sounds great. Can you talk a little bit more about because we just have a few more minutes, but this is the first time I'm hearing about nasal CPAP versus like full mask. Can you talk a little bit more about that? Like
Sure.
what the difference is between the two and tolerability?
Yeah. So first of all, let me do a little myth busting. A lot of people, even your sleep technologists, will say, "Oh, well, they said they're a mouth breather."
Mhm.
You know, everybody who has sleep apnea is a mouth breather when they sleep. There's a reflex that when you begin to obstruct in the posterior pharynx, you open your mouth. And so everybody is. But a lot of times when I'm talking to them in the office there, I can see, I can watch them and I can see that they're breathing perfectly comfortably with their mouth shut. So, they're not all a mouth breather all the time. So, and they've done studies to see which patients need a nasal versus an oronasal type of mask. And the symptom of mouth breathing has zero correlation with that. So you should just take that off just take it out of there. It's not there. At the end of the day, 2/3 or maybe even 70% of patients can be managed with a nasal interface. And, for nasal interfaces, we have masks and we have pillows and cushions, kind of all related. Why is the nasal approach better? Well, first of all, actually compliance in big studies is always better with nasal only masks. Second of all, the treatment pressure is actually lower by about 1 to 2 centimeters of water with nasal masks. Dryness and leak is less with nasal masks. So for all of those reasons, you really should try a nasal mask first. Now, how do you get the fit on the nasal mask? I'm going to write down the name of an app in the chat here. Let me see if I can remember it. MaskFit HR is an app that patients can load onto their smartphone. Um, if you use like an Apple phone, you can do it with a Android as well. But those of you who have Apples, like when you pull it up, it knows it's you because it's measuring your face. So this app actually uses that capability to measure your face to within tenths of a millimeter, and then it maps your face against the database of all the masks that are likely to be sold. And it will tell you, along with some other things, what masks would be good ones to try first. So it's not bad. It might not be as good as your most experienced technologist or nurse who does this fitting, but it's way better than your high school student who's doing it part-time at the DME store.
Fair enough. Okay. Do you have to specifically request on the DME for the nasal? Because you said basically the DME companies will try to push the full mask.
Yeah, you'll have to see. I mean, with the DMEs around here that we deal with, we send them with a recommend this mask or recommend nasal interface, and they'll honor that because otherwise I won't send the patients there anymore. But you may have to limit it. Now the DMEs, it takes an education process and a bit of back and forth because they really there's a lot of myths to dispel, but this is a thing. I mean, we're seeing this now more and more in the sleep conferences and in our center and so forth, that really we should be trying nasal masks first.
Okay. Like we talked about, we're finishing a little bit early today, but so we'll stop it there. I don't know if you have any final plugs or pieces of advice before we end it, Dr. Morgenthaler.
No, I've enjoyed the opportunity to share with you. I hope the things I've told you are helpful. I think they're mostly true. And looks like Michelle has a hand up or something. Maybe she has a question.
Oh, quick question, and I apologize if you just said this, but the Inspire, what is the AHI criteria or the BMI criteria?
So the Inspire, they have to have at least moderately severe obstructive sleep apnea. And most of it, vast majority of it has to be obstructive. So again, some of your home sleep apnea tests may not be able to differentiate on that. Depending on where you are, some centers or surgeons will require you to do an in-lab study for that reason. But they must be at least moderately severe. I think the upper limit is 85, can't be worse than 85, might be as high as 100, I don't remember. AHI. For BMI, the FDA now approves up to a BMI of 40. When it first came out, it was 32, and then Medicare politically lobbied and got it raised up to 35, and now the FDA has approved it up to 40. Now, having said that, I just, again, let's be scientists for a minute. BMI less than 32 has an 8 times higher likelihood of having a successful outcome than if the BMI is higher than 32. So, your patient that has a BMI of 40, I would really push on them to let's use CPAP and weight loss until we get you into a zone where you're more likely to succeed. Because, the ads on the NFL football games that show the easy button Inspire are lying to you. I do Inspire. I think it's got a real role. I think it's a good treatment for many people, but it is not easy. It doesn't just, I would say we have more, if you say what's the smooth path, I think we have more rough paths that eventually get there than smooth paths. It takes a lot of back and forth. So.
And we just have one more question, and I think this is another hour-long talk that I'm asking you to give a 1-minute answer to. But we have a question about what do we do for people who don't tolerate CPAP in some form or fashion? Dr. Crowley's asking, do you ever try to use like a sedative or an anxiolytic, or is it a mask change immediately?
Yeah. So it is a hard question because you first have to find out why.
Right.
Why. And again, it might be that you're seeing already that they have a bad fit. It might be, but the other thing that is an important why to ask is you kind of have to step back again and say, how did we get here? Treating people's sleep apnea will help with some insomnia, but a lot of people with who have sleep apnea have comorbid insomnia. Of course, we have to have a name for it, COMISA, and you have to address the insomnia also. And healthy sleep habits and so forth. We know that they will be much more likely to succeed. And so, again, the kind of complicated answer, when they say they don't tolerate it, we have a lot of referrals to us, CPAP doesn't work. And after we work with them for a bit, many of them go on to succeed with CPAP. Okay. So it's paying attention to the details, finding out what exactly is wrong. Yes, it might be a poorly fitting mask, but if you don't know that, just sending them back to the DME, go get a different mask, it's kind of a crapshoot again, right? You don't really know what they're going to do. I would say if you haven't already used a digital mask fitting app like, MaskFit, maybe do that. Find out what would be the better fit. But also we have to be, you have to commit yourself to the patient and enter into a union with them to say, look, let's stay at this till we find something that works. There are people who really just can't tolerate CPAP. And you may be one of those people. I don't know that we're there yet. But if we really come to the end of the road, we can't do that. Guess what? We have alternatives. We'll go find something else that works. Don't let them give up.
Yeah, that's perfect. Again, like such a concise answer for such a difficult question. We can't thank you enough, Dr. Morgenthaler. This was enlightening. Yeah, I mean, I figured this would be amazing, but I mean, you even kind of blew it out of the water. So we appreciate your time so, so much.
My pleasure. And all of you have happy holidays.
Thank you, you too. Goodbye, everyone.
Bye bye.